Okay, thank you very much. It's a pleasure to be here and always a pleasure to meet you all. This is a joint presentation between the Liverpool Ocular Oncology Research Group, which I lead, and the Liverpool Ocular Oncology Service, which my husband Heinrich Heimann leads. I just want to mention that this is a team effort, and everybody in this team is important, but I'd just like to highlight some people. Obviously, the surgeons who perform the intraocular biopsies, and these are predominantly Karl Grönwald and Romana Hussein, who is a second consultant in Liverpool. And then the unsung heroes behind the scenes, who are the technicians, such as Simon Bidhoff and Sophie Thornton, who prepare the samples and then do the molecular analysis. And then Helen Callery, who is my senior postdoc and who also supervises not only the molecular pathology service, but our ocular oncology biobank. So I have no financial conflicts, and I'm just going to provide you with an overview of what I'm going to take you through in this next 30 minutes. So a few slides from the Liverpool Ocular Oncology Centre and some videos, and you'll have to have patience with me because here I am as a pathologist explaining the surgical videos, and there is a bit of, could be a bit of leeway for misinterpretation there. So people in the audience might have to help me. So the Ocular Oncology Centre, as you know, in the UK, there are super regional referral centres, and these are the statistics from 2016 in terms of the number of new patients seen and then the number of patients who were diagnosed with uveal melanoma. The numbers are pretty much the same in 2017 and it would appear similar in this year. So in Liverpool, we aim to have a joined up and personalised healthcare system for the ocular melanoma patients. And so you probably heard yesterday from Bertel the management of the primary tumour, and you'll probably hear some more in the next couple of talks. But just to give you a brief overview, this is the breakdown of those 265 patients. You can see that proton beam and ruthenium plaque plays a major role in the treatment of the uveal melanomas. Obviously, still quite a proportion of the uveal melanoma patients have their eyes enucleated for varying reasons. When there is enucleation or surgical resection, then the patients are spoken about, and the concept of having their tumor tissue analysed using molecular tests is explained. Then in no way coerced to have this done. There is an extra consent form which has to be signed by the patients if they would like to have the molecular testing performed. And it's actually through probably the internet and the information that you can receive through there, a lot of the patients come in requesting that they have the prognostication testing. With the radiotherapy, patients are also offered an intraocular biopsy either before or after, and I'll come back to that, the procedure. And there are some cases where, and I'll also show some examples of that, where the lesion is atypical and it's indeterminate, and a biopsy is undertaken to establish the diagnosis. So prognostication, and I'll go through that in more detail soon, is essentially to determine the risk group in terms of what the likelihood of developing metastasis is to the liver. And when you look at all other cancers, there is no such strong prognostic parameter as there is in uveal melanoma. No other cancer type, in either male or female cancers, is there such a strong molecular test which would indicate that there is going to be a risk of spread. So I'm just going to go through the indication and techniques. So this is a breakdown of why intraocular biopsies are performed. So the vast majority for prognostic purposes, but others for diagnostic purposes, differentiating between a melanoma and perhaps a metastasis of an unknown primary to the eye. And I'll show you an example of that. And then with respect to prognostication, the techniques which are performed is either transscleral or transretinal. And I'm just wondering if we could have the lights down a bit, because now we're moving into the scary area, because this is where I'm going to try and explain some videos. I don't know whether we can turn the lights down here. So this is a transretinal biopsy. Is it going to work? Yes. So this is, let me see if I can get the sound up. So this is this instrument which is used to be placed into the tumor, and you'll see that shortly. It's connected to tubing, which has a three-way valve. You can see the probe going without vitrectomy, going straight through the retina, trying to avoid any blood vessels within the retina, and then going into the tumor. You can see that there's one light, and there's another tube which provides fluid to maintain the pressure within the eye. The probe comes out, and then the pressure of the fluid is increased slightly. The sample is in here, and then a syringe with just some saline is then flushed through this three-way valve, so that the probe is then flushed into this tube and then sent to us in the laboratory. And you could have seen that there were tiny little bits of the tumor in the tube, and they essentially continue doing that biopsy or taking the biopsy until they see something in the tube. Now, moving on to the next video. This one, again, is a transretinal biopsy. And this is to show that a complication of the intraocular biopsy is transient bleeding. And this is to show that one can use the actual probe, which is for taking the sample, can be used as a tamponade to reduce the amount of bleeding. So as they were removing the probe, then there was a tiny bit of bleeding, so they put the probe back onto the wound, so to say, so to reduce the amount of bleeding taking place. However, this is just an example that of where perhaps a case can be a bit difficult. It seems to be straightforward. The biopsy being taken, the probe being removed, sample being flushed, but then they look back in the eye and they see this little hemorrhage. So they go back in again and then clear the transient hemorrhage. So that's a transretinal biopsy. There is a procedure which is undertaken in Liverpool and other places called an endoresection. I can't get this video working, so I'll just skip onto that, but then there's a larger amount of tumor material available. And then this is a transscleral biopsy. So the tumor is marked. So this is looking from the outside of the eye, and through various procedures that you can highlight where the tumor is, and so that's marked on the outside of the eye. And so this is where a flap is created. So you go halfway down into the sclera, and a flap is created, and then go in with a scalpel down to the level of the choroid, and then using what are called alligator clips, a biopsy is taken, and then the wound is sealed with glue. And then following that, a plaque is placed on the wound. So how do they do this? So proton beam, they take the biopsy either via transscleral biopsy or transretinal on the last day of treatment. With a ruthenium plaque, it used to be before a plaque placement, immediately before. Increasingly, it's following the plaque therapy, just to minimize any risk of tumor spread. And then similarly, if there are these indeterminate lesions where it's not quite, people aren't quite sure what is the tumor, the choroidal tumor, then it's a mixture of transretinal and transscleral. So I just wanted to show you an example of a choroidal metastasis of a carcinoma. So these are actually the most common choroidal tumors. These are metastases from tumors elsewhere in the body, with the breast carcinomas being the most common primary tumor in females and lung carcinomas in males. And so these are the type of samples that I receive, and I looked in under the microscope. I can do special stains to highlight that these are epithelial cells, not melanoma cells. And then I can go on and look at various proteins and hormones, which are important, for example, in breast carcinoma, HER2. The patients are treated with HER2, anti-HER2 therapy. You may have heard of tamoxifen. And if it's a lung carcinoma, we look for the mutations of the EGFR receptor, and if they're present, then the patient is put on this particular medication. So it's not only for choroidal melanoma that the biopsies are performed. So there's always a learning curve with intraocular biopsies, and indeed this was seen in the Liverpool cohort, and an audit was undertaken where two sort of groups were analysed between 2011 and 2012, and then a second group, during which the surgical procedures were improved. Similarly, in the laboratory, the yield was improved. And this was meant to show that there was a similar distribution in terms of size in both group 1 and group 2. These were the complications, transient hemorrhage. There were some significant hemorrhage in some cases, and you can see that otherwise there are minimal complications. Overall, Andre Grixty did a review of all of the intraocular biopsies performed in Liverpool up to 2014, and at that stage there were about 1,500 biopsies for both melanoma and metastatic disease. And there were indeed complications such as endophthalmitis, so infection within the eye. That's always a nightmare complication. And there was local dissemination, so spreading of fine tumor cells onto the sclera. However, these cases were then treated with additional plaque therapy, and we analysed these. And out of interest, they tended to be the more aggressive uveal melanomas with the monosomy 3. So this is if you look at this paper, that's quite a detailed graph, but essentially it's to say that there was a whole range of different tumor sizes, and the major changes during this period was that the change in the practice of the transscleral biopsies wasn't using a fine needle biopsy, rather they were doing the scleral flap, and also the persistence with the transretinal biopsies, making sure that they actually saw something in the tube before sending it to the laboratory. And then with tiny samples where we had very small DNA extracted, then we used an additional technique. So if we look at the results, so looking up in the first group, the success rate in terms of cytology, what I could see under the microscope, was 92%, and the genetic yield was 75%. We weren't happy with that, but then through the revisions of procedures and the techniques, the cytologies improved to 99%, and the genetics up to 93%, and indeed a recent audit we've found it's 96%. It's not 100%, we'd like it to be 100%, but there are always the very difficult cases where we only have perhaps 1 or 2 cells in the tube or in the pot that comes to pathology, and there just isn't sufficient material to do the genetic analysis. So, but over time, what has become apparent is the size of the tumor in which the intraocular biopsies are being performed is decreasing, And you would think possibly that these are, because they're small, they're not all that dangerous, but actually all of these tumours were monosomy 3 tumours. So, and this did have consequences, obviously, with the further management of the patient. So just moving on to the controversies regarding molecular techniques, and I don't really want to get bogged down in details here, but I just, as you know, this was the landmark paper of Gabriele Prescher in Essen in Germany, and they demonstrated this quite distinctive prognostic or clinical course with the absence of chromosome 3. And this was confirmed by a number of groups, including Valerie White in Vancouver, others in Sheffield, and ourselves in Liverpool. So there are a range of different techniques which can be used to determine the chromosomal alterations in uveal melanoma. So the FISH, MLPA, microsatellite analysis, array CGH, which are all used in differing centres. So we used FISH for a long time, between 1996 and 2005. However, we found on doing an audit that it really wasn't specific enough. There were patients who were given the diagnosis of, yes, uveal melanoma, disomy 3 tumour. However, they did go on and develop metastases. So we wanted a more sensitive test, and we looked at this DNA-based technique called MLPA for short. We initially tested it out on biobanked samples with all of the clinical information, and then we went through the various loops to introduce it into the NHS, and since 2011 we have been using MLPA on not only the larger surgical samples such as local resection or enucleation, but also on the intraocular biopsies. We did find that for MLPA you require a certain amount of DNA from the tumour cells. And if you have very low content from a sample where you only, say, have 4 or 5 tumour cells, then we use this technique called microsatellite analysis. This is all performed in a molecular laboratory which undergoes external and internal quality assessment. We found also that we got sufficient DNA following proton beam therapy and also following plaque therapy. So this was a paper which was published by Ramana Hussain, who showed that in 104 patients we did obtain sufficient DNA from the samples following radiotherapy, or following proton beam therapy, and that the survival curves were very similar as to what we saw from patients if the biopsy was taken pre-radiotherapy. And this has been seen by other groups. So Werner Backernagel in Austria showed that using his technique of array CGH. Although people in Leiden, when they used FISH on formalin-fixed paraffin-embedded material, they didn't come up with similar results. So in the meantime, we've probably done at least 1,000 MLPA testing of uveal melanoma. This was a summary of 602, and you can see the survival curves, which are broken down into essentially 4 groups. It's quite distinctive when we look at the scattering of the results in terms of chromosome 3 loss and 8q gain. Similar results were obtained by the Paris group using array CGH. You can see very similar curves to what we obtained using MLPA. And so there seemed to be 4 risk groups, and this was also validated or confirmed using by the TCGA, the Cancer Genome Atlas. I think I spoke about this in more detail last year, where there are 4 prognostic groups on the basis of the copy number variations of the chromosomal alterations, and also the mutational status of the tumour cells. So these are the 4 subgroups, which are essentially based on chromosome 3 and 8q gain. Then if you map those onto the mutations, you can see that the good prognostic, the very best prognostic group, has alterations in what's called IFACs. then you have the beta group 2, which has alterations in SF3B1. Group 3 and group 4 are the uveal melanomas where they have alterations in BAP1. And I think we might have spoken about that in more detail last year. But what you can do is not only look at the tumor cells for the chromosomal alterations, you can look at them also for the mutational status, but conveniently BAP1 can be tested using a very simple test using immunohistochemistry. And what we've found, and others in the Netherlands, have shown that if you have clear nuclear BAP1 staining like this, that this is almost 100% correlative with a disomy 3 tumor. Whereas if you have loss of BAP1 in the nucleus, then this more often not corresponds to a monosomy 3 tumor. And so you can do similar, I guess, survival curves according to the BAP1 protein expression. This was work done by 2 PhD students of mine. Interestingly, if you look at, you can even further subdivide the monosomy 3 uveal melanomas, and there is a small proportion where you have nuclear BAP1 positive monosomy 3 tumors, and these patients do very well. So we're finding it's very important to do this BAP1 staining on the surgical samples. Of course, there are other techniques, and you've probably heard of the gene expression profiling, which was put forward by Bill Harbour and co-workers. This is then, since this was based on a 12 signature gene subdividing the uveal melanomas into what are called class 1 and class 2 uveal melanomas. This has been since commercialized, and in the meantime there's 1A, 1B, and class 1A, 1B, and 2 uveal melanomas. I guess the considerations for all genetic testing in uveal melanoma, whatever technique you use, is the yield coming out of the samples, whether you're dealing with formalin fixed or fresh samples, how well and experienced your team is in the lab, and then you're looking at things like tumor heterogeneity, and also whether it's pre or post radiotherapy. So if we look at some comparisons, the gene expression profiling versus MLPA, they're very similar success rates, and this has been undertaken by groups external to ourselves. And so, for example, this paper by Tara McCannell, she did a comparison, a masked comparison of the 2 techniques, and there were quite good concordance between the 2 of them. Then you can also say, is a biopsy representative of the whole tumor? And we had cases where we had, first of all, the intraocular biopsy, and then for various reasons, the eye was subsequently enucleated. And then we had the opportunity of comparing both samples, the smaller and then the larger sample. And in 28 cases, we had the opportunity to do this, and there was concordance in all of the cases. This was also found by a group in Copenhagen. Jens Kielgaard used a different technique to demonstrate that there was concordance between the small biopsies and the full resections. Gene expression profiling, I think in most cases there is concordance. However, there was this study done by James Augsburger who demonstrated that there were discordant results in up to 11% of the tumors examined. So what do we do with this information? We don't believe you should look at the molecular results just in isolation. You should bring everything together in terms of what we call a holistic approach. And there is this Liverpool Uveal Melanoma Prognosticator Online model, which was designed and validated several times by Professor Azam Taktak, who is a clinical statistician. And this takes into account various clinical parameters, then histomorphological parameters. And the first version of this prognosticator model also only took into account chromosome 3. So this is online. It was designed with this number of data sets, and then it was validated not only internally, but in the meantime externally by 2 other independent centers. It is online, and so you can use Google Stats to see how often it's actually being used. And over the years, you can see that it's increasingly being used by a number of ocular oncology centers across the globe. So in the meantime, it's been revised, and chromosome 8q has been added to the prognosticator. This is still in trial. And it's in process of being validated through a multi-center collaborative study through the Ocular Oncology Group, which is based predominantly in Europe. So other new developments. So the TCGA has spurred people to design what are called next-generation sequencing panels, which are bespoke for uveal melanoma. That Castle Biosciences published theirs at the beginning of the year. Almost simultaneously as the next generation sequencing panel, which was put forward by analysed and Imani Kilic in Rotterdam. And we too have our variation of a next generation sequencing panel, which has been designed and worked up by our molecular technician and also PhD student Sophie Thornton. So why patient stratification? I think we've gone through some of these arguments yesterday. If we're to come up with our magic bullet or bullets, then I think it's good to know that we're quite good in stratifying those patients who are at high risk of developing metastases, and so that ultimately the aim would be to commence adjuvant therapy before anything is clinically apparent on MRI scans. Studies have shown previously that by doing intensive MRI screening, you can pick up the metastases earlier, and some of those patients are suitable for surgical resection, and that the survival rate is prolonged following the resection. This is the Liverpool's studies, but similar data has been published by the Paris group. There is demand from the patients for prognostication, and something that I won't go into because it was discussed yesterday by Yannis, the involvement in clinical trials. There is a definite need for new trials and new therapies, which I'll very briefly flash this very complicated slide, which was shown by Andre yesterday, because we're trying to address all of these so-called signaling pathways within the cytoplasm of the uveal melanoma cells. So either this pathway, which is activated in approximately 82% of the uveal melanomas, or this pathway in the remaining one. And something that just came out very recently in September was this work from the States, which showed that an agent or an oil which comes from primrose seems to be able to inhibit the G-alpha Q, which is the from that diagram that I showed you, is one of the first mutations which is present in the uveal melanoma cell. So there's a lot of work still to be done. We're hoping through the consortium of UMCure 2020 that we will be able to make progress. These are the partners which Andre mentioned yesterday. I'm responsible essentially for coordinating the biobank, the virtual biobank, and also doing histological analyses of some of these in vivo and in vitro models. And finally, I'd just like to remind you that there is the UMCure 2020 meeting in Liverpool on November 30th, and you're all welcome to attend the patients' meeting, which will be in the afternoon. And last but not least, I'd just like to acknowledge all of the people in the clinical team and obviously in the research group and many of our funders, and of course Ocumel UK, who have always been very supportive. So with that, I'd like to thank you very much for your attention, and I'd welcome you to Liverpool.